of the KB method and fetal maternal hemorrhage. The rhesus factor is a red blood cell surface antigen that was named after monkeys in which it was first discovered. As we all know, when we talk of blood bank, we cannot miss knowing the rhesus factor. The rhesus incompatibility, also known as RH disease, is a condition that occurs when an individual with RH negative blood type is exposed to RH positive blood cells. And this leads to development of RH antibodies. So when we look at antigen-antibody reactions, we'll all know that the antigens, when exposed to the antibodies, there is antibody-antigen reaction. And these antibody-antigen reactions can lead to formation of complexes and certain immune reactions that can make the body to respond in a certain physiological way. Sometimes this can be detrimental to health, and because some cells are attacked and they die. Also, there are issues concerning with the serious immune responses due to especially RH or ABO incompatibility. So in particular, we are going to look at the rhesus incompatibility here between the mother and the baby. Now, RH incompatibility can occur by two main mechanisms. The most common type occurs when a rhesus negative pregnant individual is exposed to a rhesus positive fetus or fetal red blood cells. Secondly, to fetal maternal hemorrhage during the course of pregnancy for spontaneous or induced abortion, trauma, invasive obstetric procedures, or normal delivery. So there are two things here. It can occur, actually three. It can occur due to pregnancy. And in this pregnancy, there can be spontaneous or induced abortion. There can be trauma in this pregnancy, invasive obstetric procedure, or normal delivery. And again, as we are going to look at, we will also realize that there are issues also that can sensitize the mother to induce fetal maternal hemorrhage, especially blood transfusion. Blood transfusion or exposure to a foreign organ. We all know about graft versus host disease. So there are three mechanisms in which RH negative pregnant individual can be exposed or sensitized. However, we are going to look into details about pregnancy in this case. RH incompatibility can occur when a rhesus negative individual of childbearing age receives an RH positive blood transfusion. In part, this is the reason that blood banks prefer using blood type O negative or blood type O rhesus negative as a universal donor in emergency situations where there is no time to type of cross-match blood. So the absolute universal donor is O rhesus negative. However, in general term, we usually talk about rhesus, blood group O positive. However, that's not absolute blood universal donor blood type. When it's rhesus negative, then it's universal, absolute universal blood fit for donation. To prevent the formation of anti-RhD antibodies, RHO, that is D-immunoglobulin, is indicated. That is anti-D. Before 12 weeks of gestational age, in the setting of rhesus D-negative mother, and FMH mini dose of 150 microgram of anti-D immunoglobulin is given. This dose suppresses the immune response 2.5 mils of Rh positive red blood cell. So we should be aware of that, especially the clinicians who are involved in blood transfusion. After 12 weeks of gestation age, a dose of 300 micrograms is recommended. This standard dose of anti-D immunoglobulin, that's 300 micrograms, covers FMH up to 15 mils of fetal red blood cells, and that is 30 mils of whole fetal blood. So you see, these dosages are specific, and if they're specific, it brings into our mind that this hemorrhage has to be quantified for us to go into specific dosage. If we are not going to specific dosages, then there is no reason as to why the RhD drug can be offered to a patient or a pregnant woman who is suffering from FMH. That means that lab is very critical in decision making and life saving. There are times when additional dose is necessary due to massive red blood cell fetal maternal hemorrhage and subsequent maternal immune response. This is when the KB, the Kleinhauer-Betke test is essential. So this is what we need to consider, that the KB procedure is very critical in life-saving, especially when we have FMH. The clinical significance of FMH assessment, as a continuation, the fetal maternal hemorrhage can lead to severe long-term consequences for the fetus due to chronic massive blood loss, including high mortality rates of 8% to 38%. Now this percentage, you see, with this wide spreading over wide margin, 8 to 38% depends on how quick, how fast it was detected, and the interventional measures, and the accuracy of these measures being undertaken. It can lead to cerebral palsy, neurological injuries, that is the rate of 4% to 18%. There are also developmental delays, and there are severe cases that may result in stillbirth. So you see, the consequences of FMH can be so severe, and adequate measures should be taken to address this, especially when we have a rhesus negative mother who is in question. In this historical background of Kleinhauer-Betke, that's KB, test KB, we go back to 1864, whereby Kober, a person named Kober, noted that hemoglobin F was resistant to alkali denaturation with sodium hydroxide, much more than adult hemoglobin. It was further determined that when immersed in citrate buffer, pH of 3.3, the hemoglobin F remained intact, while the hemoglobin A leaked out. Utilizing this property, the KB test was first described in 1957 by Eno Kleinhauer and Klaus Betker. The KB test is an acid elution assay performed on maternal blood to determine the amount of hemoglobin F that was passed into maternal circulation. So as we look at this background, we realize that in 1864, this person named Koba identified hemoglobin F being resistant to alkali denaturation. That's sodium hydroxide. However, currently, the procedures, as research continued, it was realized that acid elution was more effective than alkali elution method. So that's why it was recoined KB acid elution assay, not alkali elution assay. But still, sodium hydroxide as an alkaline solution can be used. So the KB test is an acid elution assay performed on maternal blood to determine the amount of HbF that has passed into maternal circulation. So what happens is that when the mother and the baby have incompatible rhesus factor, it means that the mother is rhesus negative and the baby, the fetus, is rhesus positive. And that has to be a condition for us to consider KB as a valuable element in this. KB and also FMH. Let's bear in mind that there has to be a pregnant woman who is rhesus negative and a baby who is rhesus positive. The process exposes maternal blood smears to acid solution. Hemoglobin F resistance to acid remains intact, whereas hemoglobin A is removed. Following this, the smear is stained with Shepard's method. The fetal red blood cells are left rose pink in color, and maternal cells appear ghost-like due to absence of staining. Shepard's method is just like Klenhoa-Bethke. However, it's a little bit modified, but it's almost one and the same thing, because the procedures are the same, but there is also a little, what the difference is, there is a change in the staining solution and the counter stain. The fetal red blood cells are left rose pink in color, and the maternal cells appear ghost-like due to absence of staining. Through manual detection and quantification, although manual detection and quantification has been widely used, flow cytometry was more precise and is more precise and may be utilized also. So this is not, it's not cast on stone that we should use KB method, but KB method, I'm going to emphasize on it because you see Kenya is a third world country, and most of our facilities are low resource facilities. And not many of our facilities have flow cytometry. So in knowledge of this, we are going to realize why KB method is runs supreme in saving countless lives, especially in third world nations, because we all know that maternal mortality, baby and maternal mortality in this country is quite high, and miscalculation, especially of or misdiagnosis of FMH, can be common and is one of the major contributor of maternal maternal and child mortality in a country like ours. A total of 2,000 cells is counted. Calculating the fetal to maternal cells percentage is used to estimate the total amount of FMH. The calculation is percentage of fetal red cells, which is equal to the number of fetal cells times 100 over the total number of RBCs. So the percentage of fetal cells is calculated this way. First of all, we obtain the number of fetal cells. The fetal cells are the cells that remain intact, that are not eluated by the acid. So they remain intact. However, we must count all the cells. The ghost cells, the ones that have been destroyed by acid elution, plus the intact cells, those are fetal cells. We count all of them. And then we divide by the number of the total number of RBCs, and then we multiply by 100. And the total number of RBCs we should consider as 2,000, because we count up to 2,000 red blood cells, both fetal and maternal. When you look at this image, this is what we infer. The image outlines the sequence of events. First, image A, a rhesus negative pregnant woman is involved. And we see that the baby she is carrying is rhesus positive. So the rhesus positive fetal blood enters into mother's circulation. Now what happens is that the mother, when this fetal blood enters into mother's circulation, the mother's immune system will recognize these rhesus positive cells that are circulating in her body from the baby, that they are foreign. And this is a form of graft versus host disease. There is immune reactions that usually that occur and leads to antigen antibody incompatibility, leading to fetal maternal hemorrhage and what we call hemolytic disease of newborn. And first, something that's very important that you should know is that it is always safe in the first pregnancy, because unless there was initial sensitization through blood transfusion or graft or organ transplant to this individual, is when it can be risky. However, if there is, if it's first pregnancy without issues of transplantation or graft versus graft transplant or blood transfusion, and then it can be safe. There will be no fetal maternal hemorrhage. So when we look at figure D, future pregnancies with Rh positive fetus, these pre-existing antibodies can cause the placenta and destroy the infant Rh positive red blood cells. So in second and subsequent pregnancies, the rhesus positive antibodies will cross the placenta and destroy the infant's Rh positive red blood cells because of previous sensitization. So that's why second pregnancies and also other subsequent pregnancies are at risk, especially when there is no intervention. This destruction of fetal red blood cells causes Rh disease of the newborn, known as hemolytic disease of fetus and the newborn, as I've mentioned before. The most common cause of Rh compatibility occurs when a small amount of Rh negative maternal blood mixes with Rh positive fetal blood during the course of pregnancy or delivery. When significant volume of blood from fetal circulation leaks into maternal circulation, Sensitization may occur leading to maternal antibody production against the foreign RH antigen. So this is just a repetition in various forms for emphasis. Yeah? So there is an issue called isoimmunization and de-immunization. As I mentioned earlier, pregnant and more especially postpartum D-negative women are at risk of becoming de-immunized in response to FMH or D-positive blood. So they need to receive an adequate dose of anti-D, that's immunoglobulin D, to destroy all the fetal RBCs in the circulation in order to prevent de-immunization. So there is an antidote to this. So this is the reason as to why in second or subsequent pregnancies or post isoimmunization, and then first pregnancy, because isoimmunization can also sensitize the pregnant woman, especially in the first pregnancy. And isoimmunization, as I've said, it can be due to graft transplant or blood transfusion. The next thing we are going to look at is Klein-Hauer calculations. The Klein-Hauer-Betke test calculations involve 3 steps: determining the percentage of fetal red blood cell, that's percentage of red blood cells, by calculating the volume of fetal maternal hemorrhage, FMH, and finally determining the number of vials of RH immunoglobulin required. So in acid dilution, this is what we observe in our slides, especially when we completed the staining method. So you can see the ghost cells that are not clear in the background, and those ghost cells they're associated with hemoglobin A, adult hemoglobin. That means that those are maternal cells. Then we can see the fetal cells, which are intact and very, very clear. Things to note about AMH, acute maternal hemorrhage, or fetal maternal hemorrhage. This is not required for non-severe sensitizing event prior to 20 weeks of gestation. When a woman is known to have anti-D, when a fetus stroke baby known to be D negative, when a woman is D positive, in D positive women with unexplained abdominal pain in late pregnancy, FMH by acid dilution is of limited diagnostic value. As I started mentioning, that FMH, if we have to consider KB method in FMH, first of all, we have to ascertain that the woman is a rhesus positive, the woman is rhesus negative, sorry. The woman is rhesus negative, and the baby is rhesus positive. How can we know that the baby is possibly rhesus positive? This is the reason as to why we need, sometimes it's important to consider the blood group of the father, because the baby can inherit the rhesus positive antibodies from the father. So this is key in this consideration. Then, after knowing this, that the baby is rhesus positive, then we should consider it. Then we should also consider the age of pregnancy. we should also consider the status of immunization, of anti-D immunization. So these are things that we need to consider. So when all these have been clarified, then these procedures will be of diagnostic value. So we have this algorithm for decision making. So we have this suspected FMH. We need to initiate prompt testing. If we find that maternal we find about maternal resus status, D positive or D negative antigen variants, or D weak or partial D, then we have to go and do Krenoha testing, or KB testing, or flow cytometry. When maternal RD status, in maternal RD status, we find that the mother is D negative, we have to do Rosette screen, and then we check whether Rosette screen is negative or Rosette screen is positive. I will explain briefly in the coming slides what Rosette screen means. So if we have a Rosette screen that is negative, it means now we go to FMH, assessment. FMH requiring greater than 1 vial is unlikely. This will be if it will be negative if fetus is D rhesus negative. It can be false negative if fetus stroke neonate has weak D phenotype. So sometimes the weak D is the weak D phenotype should be considered when we found certain quantitative values, especially when we've done FMH. We have assessed FMH as a quantitative assay, and we've found that FMH is quite low, and we need to consider whether to give a certain dosage of anti-D or avoid giving this dose. So if Rosette screen is positive, the KB test or flow cytometry can follow. And we should consider that KB can be positive if the mother has a positive direct antiglobulin test and or autoantibodies. So this can bring about false positivity. So we should be aware of this especially when we are doing our cross match. We should calculate the volume of FMH and the dose of RhD, that is anti-D, according to American Association of Blood Banks guidelines, AAB guidelines. The Rosette screen I was talking about is a rapid qualitative test used in Rh negative pregnant individuals to detect if fetal Rh positive red cells have entered their circulation. This indicating a possible significant FMH that might require extra RhD immunoglobulin. So there is a threshold of FMH that we should consider, as we saw in the algorithm. So if it's greater than 1, then we need to consider proceeding with that it meets the threshold of giving anti-D immunoglobulin. It works by mixing. What to do, you just mix maternal blood with anti-D. So if there are any traces of rhesus positive, if there are any traces of rhesus positive the rhesus, the RH positive antibodies in blood, it means that there has been fetal maternal hemorrhage. That means the fetal cells have leaked, or RH positive cells have leaked into mother circulation. With the rosette screen, you are able to see clumps that usually form rosettes, and they are visible under the microscope. So when you mix maternal blood with anti-D and indicator cells, you'll always see these clumps. And when you see them under the microscope, then there is FMH. A positive test shows that means many rosettes prompts a quantitative test like KB test to determine the precise amount of ROGAM, that's anti-D immunoglobulin needed. While negative test usually means a standard dose is sufficient to prevent RH sensitization in future pregnancies. Now, we start with sample collection. A blood is usually taken from RH D negative mother. Then we incubate this blood sample. And then we mix with the anti-D, which binds to rhesus positive cells, and RH positive indicator cells are applied. So under the microscope, we are going to look for rosettes. That's clumps of indicator cells surrounding fetal cells. So as we saw, the fetal cells are usually intact during acid dilution. But now here, we are checking whether there is rosettes forming around these fetal cells. Rosettes, now we just, surrounding the fetal cells, we will see some rosettes forming around, the clumps of cells forming around these cells. The result interpretation is that it's positive when we find greater than 5 rosettes per field. Suggests that there is a significant FMH, and then a quantitative KB is ordered to measure the volume. So the threshold is greater than 5 rosettes. So having these rosettes does not mean that you automatically have to consider anti-D reagents. So this is something that this dosage is specific. So the dosage has to be calculated. Of course, there is usually a standard dose that is usually given when they are greater than 5 rosettes per field. But that is that. Less than 4 rosettes per field, we give a standard dose, and that is adequate. But now, when we find that it's greater than 5, we have to go to specific dosage. And now dealing with us now specific dosage calculation, especially in the quantitative assay. We are going to delve into step-by-step procedure of KB. First, specimen collection. After now getting the rosette screen that it qualifies, either now it has qualified for a certain dosage of RhD immunoglobulin. That means it's greater than 5 rosettes. We go to KB method. We get blood sample, which is collected usually EDTA from the mother. So this sample should be collected 30 to 45 minutes, 45 minutes after delivery. but must be done before 2 hours elapse. So this is very key. Then after this collection, we prepare the smear. Thin films are prepared on glass slides and ensure even distribution of cells. And this should be air dried for a period of usually 10 minutes to 60 minutes. After air drying, we have to fix. The dried cells are fixed in 80% ethanol or similar alcoholic solution for approximately 5 minutes to stabilize the cells on the slide. So a question might come, why 10 to 60 minutes? This time span is too wide. Yeah, this usually depends on how fast the slide dries naturally. Sometimes things like temperature and humidity are crucial. Room temperature and also room humidity are crucial for drying of cells. So it's key to consider that some of these slides can dry within even 5 minutes, but we should consider 10 to 60 minutes. Then after fixing in 80% ethanol or similar alcoholic solution for approximately 5 minutes, you stabilize the cells on the slide. This fixation usually stabilizes the cells on the slide. Then cells are rinsed with tap water and they are dried again. Acid dilution entails fixing the smears by immersing them in pre-warmed citric acid buffer, phosphate buffer solution, or at a pH of 3.2 to 3.4, and temperature is usually 37 degrees for a specific time, usually 5 minutes. This acid elutes the hemoglobin A from maternal cells, leaving them as ghost cells. Then you wash the cells, then dry them gently. You rinse them in distilled or tap water for 1 to 2 minutes and remove the acid buffer and the eluted hemoglobin A. Then we go to counter staining. Oh, no, staining first. We stain with LH acid hematoxylin for 10 minutes. This stains the remaining components like nuclei of white blood cells, which stain blue. Then after staining, we have to counter stain. You rinse and counter stain. The counter stain, we usually use erythrocin B, that's eosin. This is then applied for 4 minutes. This stains the intact hemoglobin F in fetal cells, which stain deep pink, stroke red in color. Then we go to final washing. After counter stain, we go to final washing and drying. Then after that, you examine under the microscope. You have to examine under 400 power, that's power 40, and then power 100, which is oil immersion, and then systematically count 2,000 cells. And these 2,000 cells have to entail fetal cells and also maternal cells. So why use 400x? And then why use 1,000x? 400 is for you to check the proper distribution of these cells, the proper area in which you are going to examine the slide, where cells are distributed evenly, and whether the slide has been adequately stained. But with 1,000x is where the rubber meets the road, because that's where you're going to do the counting. Fetal RBCs are usually appearing bright pink or red and fully stained cells. But maternal cells appear pale and colorless, and they appear as ghost cells, as we've seen in the slide that I had shown earlier. Calculation and QCs. Calculation, we get the percentage of fetal cells, which is calculated from the total number of cells counted, which is then used to estimate the total volume of fetal maternal hemorrhage to determine the required dose of RH immunoglobulin, if applicable. So we have a quality control procedures that you also have to incorporate. So essential quality control measures include running a positive control using cord blood with high hemoglobin F and negative control using normal adult blood. So those are known positive and negative controls that can be used so that we are certain that the process that we are undertaking is accurate and reliable. So this is what I was talking about. We get the percentage of fetal red blood cells by doing the count of fetal cells in the total slides, and then we get the total of maternal cells. We multiply by 1,000. We multiply by 100. So fetal cells over maternal cells times 100. The second formula uses this percentage to estimate the total volume of fetal maternal hemorrhage using a standard maternal blood of 5,000. We usually consider using 5,000 because roughly we estimate that the maternal blood, an adult woman has around 5 liters, that's 5,000 mils of blood. So that's an estimation, and that is a constant there. So the volume of FMH is equals to percentage of fetal red cells times 5,000 mils over 100. The third formula determines the number of vials of RH immunoglobulin needed to counteract the hemorrhage based on the volume of FMH. So the vials required is volume of fetal maternal hemorrhage that we obtained in the previous calculation over 30. Now, how do we dose? How do we calculate the dosage? One vial of ROGAM covers approximately 15 mils of fetal packed red cells, or 30 mils of fetal whole cells, whole blood. Now, this is where 30 comes from. So it's either 15 mils of packed red cells or 30 mils of fetal whole blood. Now we go with whole blood because these are not packed cells yet. We've not converted them to packed cells. So the cells as they are in the fetus. So that's why we use 30. That's why we divide by 30, as you've seen in the previous slide. So volume, vials required is equals to volume of FMH over 30. And that 30 comes from the volume of fetal whole blood. Calculate the required vials and round up to the next whole number. So if you got 3.1 or 3.3, you have to round it to 3. If you got 3.6, then you have to round it to 4. So that's what we mean. And we must add 1 vial for safety. So it's what you've obtained, you've obtained as the dosage from the FMH calculation, rounded off to the nearest whole number plus 1. If the NIF calculations yield 0, one vial is given for RH negative mothers with RhD positive babies. I.e., if you get 0, the value of 0, you must add 1. So in summary, the principle of KB is based on fetal hemoglobin more resistant to acid dilution than adult hemoglobin. And maternal blood smear is treated with acid solution. HB is washed away, leaving ghost cells, while HB remains inside the cells. Staining and counting and calculation is it's whereby we do a minimum count of 2,000 red blood cells, and then in this we obtain the number of fetal cells as the number of fetal cells and the number of total cells, which is usually 2,000. And when a question that we need to ask ourselves, but this question has been answered before. We do this when we have RH negative mothers after delivery of RH positive infant. We do it especially in obstetric events following potential sensitization events such as trauma, amniocentesis, or placental abruption. There are limitations to this because we realize that it has low sensitivity, but it's widely used and has saved countless lives globally, not only in Kenya. For more accuracy, we can use alternatives such as flow cytometry where it's available. To prevent HDN, we require RH immunoglobulin administered to RH negative mothers at 28 weeks. That's, you remember we were talking of less than 20 weeks. So we should, as a consequential calculation, will come to will be obtained over 28 weeks. And again, we have to be aware of the status of RH immunoglobulin immunization. Another thing to consider that the infant has to be RH positive. And this one we can, in fact, we can get it by understanding, by knowing the status, the RH status of the father, because that's where the inheritance comes from. If the father is Rh negative, then it means that they've been, and the mother is Rh negative. Both of them are negative, so the baby will inherit. You definitely inherit the rhesus negative. The rhesus negative. So inheritance of this rhesus negative will definitely keep them, the baby and the mother, safe. So there will be no need, and there will be no consequence of FMH. So KB test detects fetal RBCs in maternal circulation, guiding RhIg dosing. And in management of FMH, we regularly monitor, and through ultrasound, RH administration has to be done, and to prevent isoimmunization and RHDN. The importance of RHIG administration or anti-D administration or ROGAM administration is that it prevents HDN to reduce the risk of fetal anemia and jaundice, prevents sensitization, and also prevents maternal isoimmunization to reduce the risk of future pregnancies. So this is the end of my presentation. I really appreciate your audience. Maybe I'll welcome our moderator, Mr. Arthur, so that he'll take it up for questions and answer sessions. Thank you.
Yeah, thank you so much, Mr. Agre. This was quite informative, and I believe we have learned a lot as we participated. Allow me to go to the Q&A section so that we can answer a number of questions that have been generated and a number of comments as well. We have Abraham Lomulen, who has been in the meeting from, I think this is Lodwar County Referral Hospital Laboratory. We have Joseph Kialongila. He wants the slides via his email. We have Samuel Gachuhi from Laikipia. We have Lilian Ouma from, she has a comment. She wants the slides, but she hasn't shared his email. We have Onyango Otieno. We have Peter Ngetich, and now there's a question to you. There's a question to you, Mr. Agre, from Peter Ngetich, as you can see. And the question is FMH the same as HDN? You can address that one as we move.
Thank you. Is Rosette test same as DAT and ICT? No. The Rosette screen is just a simple procedure. You just get the maternal blood and you add anti-D. Then you check for Rosette's formation under the microscope. That is that. It's as simple as such. So it's a little bit different. Thank you for that good question.
Yeah, there's this question from Peter Ngetich. Peter Ngetich. Now the question is FMH the same as HDN?
Fetal maternal hemorrhage. Now, fetal maternal hemorrhage can lead to hemolytic disease of newborn. So one leads to the other. So FMH leads to hemolytic disease of newborn. So they're not the same, but they are closely related because one leads to the other. FMH, because the leakage of this blood, red blood cells of the infant or the fetus to maternal circulation leads to hemorrhage. Hemorrhage is caused by antigen-antibody reaction between rhesus positive of the baby and rhesus negative of the mother. So this antigen-antibody reaction leads to hemorrhage, destruction of cells in vivo. So when these cells are destroyed in vivo, this is what we call hemorrhage. And this hemorrhage, when it's severe enough, it leads to severe consequences called hemolytic disease of newborn. Thank you.
Thank you so much. We have another question from another comment from Pamela Shikitimi. She wants the presentation shared. We have Eric Kirui, and the question is there any chance of HDNB during the first pregnancy? A question from Eric Kirui. Is there any chance of HDNB during the first pregnancy? Back to you.
Thank you, Eric. That's a good question. It's possible, and there is a chance. A chance why? You remember I talked about graft transplants and also blood transfusion. Maybe the mother was transfused with blood previously in another procedure, different procedure, not associated with pregnancy, but transfusion was done. And by chance, unfortunately, maybe her body was sensitized. And this is what we call isoimmunization. If a graft was transplanted to this this mother, this is not associated with pregnancy. Now, in the her first pregnancy, because of this isoimmunization or earlier sensitization by the graft transplantation or blood transfusion, the first pregnancy, in the first pregnancy, it can be possible that this there will be fetal maternal hemorrhage and leading to consequences of HDN. Thank you.
Yeah, very well. We have Joseph Kialongila, and here's a question that goes: is there any chances of having HDNB in the first pregnancy for rhesus negative mothers and rhesus positive fathers? Back to you.
So rhesus negative mothers and rhesus positive fathers. So when we have a rhesus positive father, it means that there is a higher chances of the baby being rhesus positive, and the mother will is rhesus negative. So definitely there is a chance there that there can be HDN or FMH. So yes, that's very possible. That's very possible. Where there is a chance of, okay, where there is a definite possibility of not experiencing hemolytic disease of newborn or FMH is whereby we have a rhesus negative father and a rhesus negative mother, because the baby will definitely inherit the rhesus negative from the father, and also the mother has rhesus negative. So there will be no consequence there of leading to FMH. So there will be safety.
Thank you. Elvis Ambetsa wants the slides shared to his email. We have Eric Roy commenting nice. We have Justin Haimba. I kindly share the slides. We have Josephine Malala. I think this question you've answered already about is Rosetta test same as DAT and ICT? I think you've answered that as well. We have Adnan Makoha, who's commented that the presentation has been enjoyable. We have Elizabeth Dungu, who she says that the presentation was nice. We have George Odandi, from Port Victoria, says a good presentation, and kindly share the slides. He has provided his email address. We have Mary Mosioka, good presentation. We have got Caroline Wangari. He wants the slides. She's presented her email. We have got Ibrahim Bile Tari. He's also presented his email. We have got Ruth Mungeri. Says good presentation. Peter Gidigaro, a good presentation. Josephat Meme, Josephat Meme. There's some background noise. Can you kindly unmute? Mute your mic. There's noise in your background. Mute your mic, please. Yes, agree. You can mute your mic. Yes. Try and mute your mic so that we proceed without that noise as we address the noise, where the noise is coming from. Yes, there's a lot of noise from your background. Agree? Okay, let's proceed. We will bring Agree back. Let him try and address that noise. Meanwhile, let's proceed checking on the comment that we have. We have Josephat Meme, good delivery. Agree. Query: are there any detriments of overdosing ROGAM? Agri, you can come again and probably answer that question. A question from Josephat Meme, and he is asking, are there any detriments of overdosing ROGAM? Back to you, Agri. Yes, Agri, are you able to hear me?
Yes,
Yes, go ahead.
Can hear you. Now the question is about dosage administration.
Yeah, the question is from Josephat Meme, and he is asking if there is any detriment in overdosing ROGAM.
Now, overdosing ROGAM. Okay, first of all, there is no point of providing extra dosage of ROGAM. First of all, it's our waste of resources. I've not really done research about what the contraindications of overdosage of ROGAM is. However, we should all know that that any drug overdose is detrimental to someone's health. There are various symptoms that are given resulting from overdose. That there is no drug that is safe when it's overdosed. First of all, it's very important to remember those 2 points. First of all, now we're talking about drug and medicines stewardship. Is for us to be able to take care of the resources that we have and to prevent harm. Definitely every other drug, when overdosed, has certain contraindications or negative impacts. It's good to do a little research about that, but there are other detrimental issues that will arise, especially on someone's physiological function. Thank you for that question.
Thank you, Doc. There's a comment from Caroline Wangari. She says, a good presentation. Elisa Nangila wants the slides via an email she's presented. We have got Collins Rua, good one. Dorcas Chelagat, good presentation. We have got Beatrice Sitanda, she wants the slides. We have got Caroline Akinyi Ouma. She wants to know the charges or the price for the test. She wants to know how much is the test. Back to you.
Thank you, Arthur. You see, these are a very basic test, especially when it's done in-house. Okay, I don't know. You know, there are disparities in how labs charge, but it's a very simple test. It's a very simple test. It can be close to what we call to test like a peripheral blood film analysis. So there's no big difference between that and peripheral blood film examination because it's a very simple test, simple staining methods that are used here. Maybe what is expensive can be, especially when we are doing the flow cytometry. Flow cytometry is a little bit more expensive because it's a reference test for fetal maternal hemorrhage. I'm not sure of specifics about the prices, but it's basically a cheap test that can be done in-house if you are able to buy the stains and you are trained on the same as well. Thank you.
Very well. We have Titus Mulatia, quite interesting. Stella Marghetto, share the slides. Caroline Akinyi Ouma, kindly share the slides. We have Oscar Masila, next presentation, and kindly share the slides. We have Aflin Nundu, very informative, kindly share the slides. Wilson Jerry, very informative and precisely share the slides. You have Godfrey Kwena. So Godfrey Kwena has a question, and the question goes, so the KB test is only done when the first child results positive and the mother is results negative. Back to you.
And now, thank you, Geoffrey, for that question. The KB test is usually done, especially in the second pregnancy. Second pregnancy means that the pregnant woman was sensitized earlier, the first pregnancy, and any subsequent birth after the first pregnancy, we should know that the mother has been sensitized, and if there is any possibility of the child, the baby or the fetus being rhesus positive, it will impact their health. There will be fetal maternal hemorrhage. So that one, it means that it's very essential for it to be done in any subsequent birth, in any subsequent pregnancy after the first delivery. The first delivery will be normally safe. But if there is this question of earlier sensitization through graft transplant or through blood transfusion, if there is that knowledge, prior knowledge, or if that one is known, then it must be done. Must be done, especially over 28 weeks, so that over 20 weeks, so that close to 28 weeks or at 28 weeks, the RhD is given. Thank you.
Very well. We have Sami Oyabi, Lilian Ouma, and Elizabeth Ndungu. They are requesting for the slides. And then we have Jackson Joroge. He says very informative. We have Mary Njuguna and Peter Ngetich. They also requesting for the slides. Then we have Salim Dai. He says good presentation. Then we have Linus Kipchichir, good presentation. We have Salim Dai and Martha Njeri. They're requesting for the slides as well. Joseph Ngila, he says echo. And then we have Joshua Mangombe. Thank you for the very educative presentation. We have Beatrice Shitanda again. She's requesting for the slides. We have Sophia Simiyu, Victoria Kimomo, and they're also requesting for the slides. Now we have another question from Ngila. And it's a comment and then a question. And so he says, it is necessary to educate all mothers visiting our facilities the importance of having their husbands tested on blood group. So it's kind of like a question. He wants to know if it is significant to also allow the mothers to be accompanied by their husbands, so their husbands are also able to know their blood group during the pregnancies. I think this is what probably Joseph is asking. So probably can shed some light on the same question. Back to you.
Yes, that's a very important observation for clarification. It's very, very important, especially for every rhesus negative pregnant woman to know the rhesus of her husband. for their safety, for the safety of the baby and the safety of the mother. It's very, very key, very, very important. And this information is usually shared, especially during the antenatal visits. This can be emphasized. So it's very, very important. And there is a question also I saw, I've seen here. The question is from Ibrahim: can administration of ROGAM be given only once in life, or pregnancy or possible in all gravida? This dosage is calculated in all gravidae. So in all pregnancies, so we have to know how severe is it. We have to know for the dose to be given. Every dose that is given, FMH has to be calculated. So the procedure has to be followed in every prescription of a ROGAM dose. Thank you.
Very well. We have another comment from this is Lopeyok Josephat, and he says this is commendable presentation and informative session. We have Margaret Vata. I kindly repeat the dosage of administering ROGAM. Back to you. Agree?
Yes, thank you. If we calculate the rosettes, and we find that they are greater than 5 rosettes, then we go to FMH calculation, where first of all we calculate the percentage of the fetus, the percentage of the fetal cells, and this percentage we get the number of the fetal cells, the intact cells that we count them under the microscope, over the total cells times 100. That's how we get the percentage. And after getting this percentage, we say we get this percentage, we divide by 30. And we said division by 30 means that we are getting the 30 from the 30 meals of the whole blood cells of the fetus. That's the minimum that can leak to cause greater than 5% rosette. Then after getting that value, that is the number, the percentage of fetal cells over 30, we get the FMH number. After getting the FMH number, we round it to the whole number. We round it to the nearest whole number. So if it's 3.6, we round it to 4. If it is 3.4, we round it to 3. After rounding off, we have to add 1 as a safety measure. We add 1 as a safety measure. This we can ask ourselves, what about if we get 0? If we get 0, we must give 1 dose as a safety measure. We don't leave it that way. First of all, there was rosette that was greater than 5. And then we get 0, and then we leave it like that. And the mother is already sensitized. So it means that we are courting danger. So addition of that 1 is a safety measure to help us, especially when we get 0, and there is definitely an indication that there are rosettes and fetal maternal hemorrhage is live. Thank you. Thank you for that question.
Thank you so much. We have Martha and Jerry and Phyllis Mungai. Both of them are requesting for the slides. We have Abel Ntuki, informative presentation. We have Onyango Tieno and David Dianga. They are requesting for the slides. Then we have Adnan Makoha. Adnan Makoha has a question, and the question is there a possibility that a mother is rhesus positive and the rhesus negative, and the baby, and the baby is rhesus negative, and how do you go about it? Is there a possibility? So I think
Thank you.
before you answer that, there's a response from Lopeyok Josephat, so that you're able to at least tackle both. And the response is, this one depends on what the child will inherit in a scenario where the mother is rhesus negative, is rhesus D positive, and the child inherits a negative from the father. This is major cause of erythroblastosis fetalis. Yeah, so probably you can now weigh in and give your recommendation or direction.
Thanks a lot for that. Also, that question has been answered. Yeah, that's possible for rhesus, for us to have a rhesus negative mother and also rhesus negative child. That's no cause of worry at all, because both of them are rhesus negative. The baby will inherit the rhesus negative from the mother. So in a nutshell, it means that the couple, have rhesus negative. So there's no cause of worry in that pregnancy. But where there will be a cause of worry is where we have a different scenario whereby the baby is rhesus positive and the mother is rhesus negative. Yes. So thank you for that.
Yeah, thank you so much. Thank you so much. Titus Mulatia is requesting for the slides. We have Ibrahim Tari, and there's a question here. Can administration of ROGAM be given only once? Okay, this one you've answered already. Thank you. We have Peter Ngetich, and he has a question. What if given within 72 hours after delivery? Probably you can address that. Is it after 72 hours? Is it what happens if it is given after 72 hours? Yes, and then
thank you.
Yes.
Thank you for that question. So earlier on, I talked about the detrimental effect of fetal maternal hemorrhage, and it leads to, as someone has stated there clearly with a scientific term, that's erythroblastosis fetalis. That's basically a condition of a hemolytic disease of newborn. What happens is that the effects of FMH will lead to complications, and these complications can lead to diverse issues, diverse physiological issues, such as neurological issues. There is also issues like issues like palsy and also fatality. There can also be when FMH is so severe and it has not been detected, maybe one is working under very low resource centers or facilities, and there are no standards that are being followed, especially in making sure that there is correct diagnosis and dosage of FMH and handling the cases of rhesus negative mothers. For me, I can advise that this facility should refer immediately. These are kind of emergencies, especially when someone has not been immunized. So it's very, very important for these things to be handled as fast as possible. If there is delay, you know that there are dangers that are involved, like palsy, neurological issues. There is stunted growth. There is failure to thrive. There are many issues that can come in, and the severity of these complications will depend on how fast the issue pertaining to FMH is handled. Yes, it depends on the dosage that is given. Is it given accurately or not? So it's good to consider that timing is very, very key. Yes.
Yes, thank you. We have Kevin Ondieki. He's requesting for the slides. David Kevolu as well. Magdalene Duku says that your presentation was good. We have Doreen Namboga. She's also requesting for the slides. We have the last question is coming from Stella Mageto. You will have Cherotich Mwei also appreciating your presentation. And so Stella Mageto is asking, the mother may lose the next pregnancy or baby if the mother won't get antirogam. Yeah. She's just making a comment, and I think this is true from what
Yes, that's very true.
you've taught today. Yeah, this is true. So I think on our side, all the questions have been exhausted, but I also want to urge our members that we have more than 150 presentations in our YouTube channel. So we urge you to visit our YouTube channel so that you can at least have to refresh yourself from most of this presentation. From here, I've seen this presentation has elicited a lot of interest. And so I wish to inform you that this presentation will be in our YouTube channel for quite some time. So you can visit there and maybe refresh your knowledge while watching this one. Otherwise, we also have our Facebook page. You can also join, subscribe, and also share. You can also share our YouTube channel, join, subscribe, and also share. We also have WhatsApp groups for disseminating a number of information that we do on a daily basis. We also urge you to be part of our community. Otherwise, thank you so much. Before I close this particular presentation today, allow me to bring back Mr. Agri for his final remark, and then we'll close this particular webinar. Welcome back, Agri.
Thanks a lot, Arthur. Now, my closing remark is that this test is very crucial, and I know it's used in various facilities across the country and also globally. And also some facilities use flow cytometry, but it's a life-saving measure, can save countless lives, where we have, as we know about statistics from the Ministry of Health, there is high child maternal mortality in the country. It's quite high. And there's various regions across Kenya where this ratio is quite high too. And one of the reasons as to why that's contributing to this, one of them is a resource incompatibility. I've seen such cases, those cases are there. And they can be troubling, even especially people who don't follow treatment guidelines. So, or don't follow the essence of going to hospital. There are areas people are quite, they're quite behind in terms of knowledge. So it's very key for us to inform and to educate, and for us to be able to play our role in making sure that the society is safe. And maybe I will have this point of reflection as I close. So there are things when we do the point of reflection that doing little things positively with love has profound impact of service, compassion, and taking actions, often highlighting that saving one person is as significant as saving the world. The key themes focus on making every day count, offering hope and the responsibility. So there's a point of reflection that I will leave you with. Thanks, everyone. Thank you for your comment, the appreciation. I really appreciate too. LMSK, together with all the listeners of this presentation. I am really thankful.
Yeah, thank you, Agri, and we also thank our participants who joined us today. On behalf of Lab Medicine, I was your moderator, Mr. Arthur Imari, and I believe that you will make an attempt to register again tomorrow so that you can have another informative presentation from our next presenter as we continue learning in the LMSK platform. Otherwise, for this evening, I wish you all the very best and see you tomorrow.